Welcome back to our discussion about health insurance, and hopefully that video clarified some of the concepts and some of the ideas about health insurance that may have been a little bit confusing to you, as well as doing a quick review of some of the issues we talked about sort of in the history of the U.S. healthcare system and how health insurance came to pass. What you need to understand about health insurance also is that risk is really the name of the game when we're talking about what is the role of health insurance. And so risk is for you as someone who is walking around living in the world. It's the possibility that you might experience a substantial financial loss from a health event. Now, your probability of experiencing such a loss is determined by things like your genetics, your behaviors. If you are a bungee jumper, you are much more likely to result in a substantial financial loss from an event than if you're somebody who doesn't bungee jump or doesn't ski. If you have certain kinds of predispositions through genetics, you're likely to have greater risk of experiencing a health event that could harm you financially. So we buy health insurance to protect ourselves against those risks. What we do is we ask a health insurance company to help pool or cover that risk for ourselves as well as other people in the community. So what would they do, what the insurance company or the insurer does, is they go through a process of underwriting, of looking at and evaluating and rating the amount of risk in a particular community or population. Now, the way medical underwriting used to happen is that on the basis of your health status and the basis of a certain set of behaviors that you may or may not engage in, such as motorcycle riding or skiing or flying an airplane, they would evaluate and determine the amount of risk or the likelihood of financial loss on the part of the health insurance company if they chose to insure you. Now, because of the Affordable Care Act, that underwriting process can't be done on the basis of your health status or certain kinds of health behaviors. And so what we see the underwriting process now involves is what we call sort of a community health rating. So they have to rate and base your premium, which is a way that they determine how much risk the company is going to take versus how much you have to pay, on the basis of a much broader pool of individuals. They have to roll into that underwriting process the fact that a certain percentage of 35-year-old unmarried men may bungee jump, may ride a motorcycle, may be an airline pilot. So the risk is not now specific, and the underwriting of your specific policy that you choose to buy is not based on your individual behaviors, but is now based on the behavior of, statistically speaking, what someone in your age group and your demographics is likely to experience in terms of financial losses from health-related events. Now, there are some key principles that you need to understand about insurance more broadly. Risk is unpredictable for individuals. We don't know if you're going to get sick or if you're going to get in a car accident tomorrow, but you can statistically predict it for large populations. And so that's why we talk about pooling risk. The risk is not about how likely you are to have health insurance needs or health problems, and you don't pay your premiums based on how much utilization of your health insurance policy you've had in the previous year. Now, if you think about car insurance or other kinds of insurance that exist out there, what you of course see is that we do pay based on the utilization of our of our other insurance, like car insurance. If you get in a car accident and you have a claim against your policy, your premium is likely to increase. We do not see that happening in health insurance. You do not get a penalty for using your health insurance more frequently than others. So it's all about, all of the rates are set just based on the risk that certain populations are likely to experience. So if you are a woman of childbearing age, whether or not you choose to ever have a child, your health insurance premiums are going to be higher as a woman than a man of the same age and the same level of health status, simply because, statistically speaking, women, of course, are going to get pregnant and have those costs Men are not going to incur those costs. That's a great example of how we have to look at not the individual health behaviors or health risks, but how we have to look globally at populations or certain demographic groups. All insured share the losses the same way. So everybody in your community experiences the same amount of premium paid, and regardless of whether you ever use that insurance or not, your premiums go into a pot that then pay for all the other sick people who also have your same health insurance company. And so the losses, or the losses that the health insurance company experiences, or the health expenditures that consumers engage in, are paid for out of all of the people who pay premiums. It's not just paid out of a certain amount. Your health insurance premiums don't go into an account that then you draw out of later, the way we do, for example, in Social Security. We don't use those resources directly. It's used to fund the expenses for everybody else. So a premium. As the video mentioned, a premium is the amount charged by your insurer to protect the company against the risks that you're likely to experience, or the financial losses that your healthcare needs are likely to result in for the company. Now, the Affordable Care Act has put restrictions on how high premiums can be based on something called a medical loss ratio. So what they do is that they cap the amount of premium that a health insurance company can charge you by saying that 80% of what your premium costs has to go toward medical expenditures. Now, of course, remember, this is all pooled together. This is based on a population level. This is not based on an individual level. So it's not as though if you don't use your health insurance in the previous year, a health insurance company is required to give you that money back. That money is being spent on others who did use their health insurance in the previous year. But health insurance companies are required to show that in a particular population, these particular community rated bands, that in fact 80% of what is being paid in as premium is being spent out. Now, you may ask, well, what's that other 20%? That's the other 20% that the company gets to keep to spend on administrative costs and to return to their shareholders. But they have to show that at least 80% is being spent. Otherwise, they're going to be required by the federal government to reduce their premiums. And so it's very important for health insurance companies to actually have claims paid out, because otherwise they'd have to reduce the premium. Of course, that's not likely to be a problem because so many people who are now signing up for health insurance have significant health needs. They were barred from having health insurance before. Now they have it, they're going to use it, and those expenses are probably going to be much higher than what the medical loss ratio requires. What we also see is that there are two methods by which the premiums are calculated. They can be calculated based on experience rating on a group's prior medical claims. This was true before the Affordable Care Act. Now we see that health insurance premiums are based on your community rating, based on your community or population's utilization. Cost sharing. This is another important concept that it's really vital that you understand. Cost sharing is the portion of the cost of a medical service that an individual consumer pays out of one's own pocket. Cost sharing can include everything, including your deductible, your co-pays, and your co-insurance. The idea behind cost sharing and why so many companies and so many health insurance companies are increasing the amount of cost sharing is to reduce unnecessary expenditures as a result of moral hazard. So what we see here is that there are many different points throughout the year, many different points throughout the healthcare encounter that you are going to be required to have just a little bit of skin in the game. And that is likely to deter you from wanting to just buy more healthcare just for the fun of it. So what we know is, you may say, well, but I don't experience moral hazard. I'm not going to buy more healthcare than I need. I'm not going to ask for extra tests. Well, it's very important to know that this concept of moral hazard has been empirically proven that it does happen. That when people don't have any skin in the game, they actually increase their amount of healthcare utilization, which actually does not result in better healthcare outcomes. And then, in fact, if you get people to reduce their amount of utilization, they actually can have better outcomes, or at very least the same. So I'd like you to watch a very short video that explains moral hazard and the RAND health insurance experiment in much greater detail, so you can really understand this notion relating to cost sharing.
My hair's so boring. I'm having such a good hair day. Did you see my bobby pin? Do you have a hair tie? Does anyone have a hair tie? Guys have it so easy. Can you take my...
So I'm trying to figure out my plan. I have to decide if I want a high deductible, want a high copay, or a high monthly premium.
Which would you rather pay the money up front or you want to pay it later?
Oh no, it's better.
It totally depends on how you like it.
Well, I mean, I guess I would like to pay it. I guess I would like it to be future me's problem rather than current me's problem.
Then
so I'd like to pay it later.
Okay, then go with a low deductible, but you're going to have high copay. You might also have high co-insurance. You're certainly going to have a high deductible.
What is co-insurance?
That's the stuff that doesn't fall into the copay, but still is responsible for you.
What?
Yeah, remember? Okay, fine. You got the premium, which is the now money, and then you got the deductible. But on top of the deductible, you either have to pay the copay or the co-insurance every time you see a doctor.
This seems inefficient to me.
This is what we get. We didn't stumble onto this system by chance. The reason all of this exists is because of a very important research study done a couple of decades ago. It's probably the most ambitious, largest study of health insurance that has ever been done or ever will be done. It was called the RAND Health Insurance Experiment, and I'm going to tell you all about it in this week's Healthcare Triage. The RAND Corporation is a think tank that was established in 1948. They perform research in all kinds of areas, including health. And in 1972, they began an 11-year study of health insurance. You see, there was an ongoing debate about how insurance affects spending on healthcare in the United States. A number of people thought that insurance caused us to spend more than we otherwise would have on healthcare. It's part of what we refer to as the moral hazard. Basically, the moral hazard is the idea that people who are insulated from risk behave differently than people who are exposed to it. For instance, if you have good car insurance, you might drive less carefully because you're more protected. In healthcare, some apply the moral hazard to say that once you have good insurance, you're more likely to use healthcare, even if you don't need it. And my favorite example of this, because I find it amusing, not because I agree, if we all had employer-paid grocery insurance, we might all demand filet mignon instead of hamburger. This would evidently lead to skyrocketing food costs, mass starvation, and huge piles of rotting ground beef. It's important to understand that people who apply the moral hazard to healthcare believe that people are using too much of it, and that's why our costs are so high. They believe that if we somehow changed how we pay for healthcare and exposed people to the true cost, they would become better consumers, and the whole system would cost less. As a theory, the moral hazard in healthcare was first described only about 40 years ago in a seminal paper by the economist Mark Pauly. And it's still just a theory. Like many theories, it has good parts and bad. It's not an undisputed law. For instance, recent work by another economist named John Nyman explains that the moral hazard may actually do good in healthcare by encouraging people who otherwise wouldn't get care to do so. We want sick people to get care. And think about it. That supermarket example isn't even remotely comparable. If I made colonoscopies free tomorrow, no one would start picking them up by the dozen. If I declared that no one would ever have to pay for chemotherapy again, you wouldn't ask for extra. If surgeons refused to accept payment for appendectomies anymore, would anyone go and get one just for the hell of it? We have a hard enough time getting people to do the things we want them to do to be healthy, without making it harder for them to do so. Anyone who loves meat loves filet mignon. No one loves going to the doctor. What really matters is whether people are getting unnecessary health care. What we'd really like to know is whether people would spend less if the moral hazard was removed, but stay as healthy. If that's the case, it's a good argument for making people pay more of their own bills. But if they get sicker, then it's a good argument for insurance covering all the costs. If you want to see if one thing causes another, though, you need a randomized controlled trial. You might think that a randomized controlled trial of health insurance would be incredibly difficult. You'd be right. There have been 2 that I know of in the history of the United States, and the RAND health insurance experiment is by far the biggest. It contained about 2,700 families, made up of people all under the age of 65. They came from 6 places across the United States to give it a nice geographic spread, and they were all randomly assigned to one of 4 levels of insurance coverage. They ranged in how much individuals had to pay in coinsurance, from none to 25%, 50%, or 95%. In other words, they measured different levels of the moral hazard. The none plan would involve no costs at all to people. The 95% plan is much like a health savings account, where almost all of the spending is out of pocket. The researchers' interests were varied, but centered on spending and health outcomes. The purpose of the study was to see if increasing the amount of cost sharing would change how people used healthcare and how their health was affected. The results are complicated and have been interpreted and misinterpreted too many times to count. But here's the gist of what they found. People in the high deductible plans, those who are most exposed to healthcare costs, did spend significantly less and they consumed less healthcare. And yes, much of that care was unnecessary, as healthy people did not suffer negative consequences from foregoing care. Removing the moral hazard did no harm in the majority of patients, which is often touted as the result of the study, because they were healthy. And of course, getting less care when you're healthy leads to few short-term negative results. So it quickly became accepted fact that increasing cost sharing was a good thing. People would use less care. They'd spend less. Insurance expenses and therefore premiums would come down. Everyone wins, right? This is why we have deductibles, copays, and coinsurance. But, and this is important, there were other findings in the RAND health insurance experiment. Poorer participants with hypertension saw their mortality rates rise significantly. They died more. This is because it turns out that people are pretty bad at telling the difference between necessary and unnecessary care. If you're not healthy and you aren't rich, then you're more likely to go without necessary care, and you're more likely to die. This debate isn't over. You can still find lots and lots of arguments from people who think that we're still too shielded from healthcare spending. They want high deductible healthcare plans, or even the elimination of all comprehensive insurance where only catastrophic things are covered. People who push for this believe that removing the moral hazard will not hurt people and will lead to significantly reduced healthcare spending. They're not totally wrong. Removing the moral hazard is fine for most people. Yes, if we make it more expensive for individuals, if we demand more skin in the game, if we remove the moral hazard, people will seek less care. And that's fine for healthy people, but it's terrible for those who are ill. So as we continue to reform the system, keep this in mind. Higher deductibles, copays, and coinsurance may be good for overall healthcare spending, but they may be bad for people's health.
At Best Buy, our experts in the Samsung Experience Shop can help you get the most from the new Samsung Galaxy S6.
So as we think about cost sharing as a mechanism for ensuring that moral hazard doesn't take place, and as a way of dealing with the fact that we need to have a way to control for healthcare spending overall in the United States, what we see is very different levels of cost sharing and out-of-pocket burden among various kinds of populations. And so what this chart shows is actually the percent of people who experience an out-of-pocket burden of greater than 10% of their income. Now you have to remember that this is before the Affordable Care Act. So these numbers are going to be much, much higher than they are today because the Affordable Care Act actually put controls on health insurance plans that cap the out-of-pocket burden. So this is sort of a before picture, before the Affordable Care Act. What we saw was that poor people who had private insurance, who were at lower than 100% of the federal poverty level, a huge percentage of them were spending more than 10% of their income on out-of-pocket costs. That includes premiums. It also includes things like co-pays. What we see is among people who are more affluent or make more money, what we see is the percentage of those people spending more than 10% of their income is increasingly very small, because in large part they can afford the lower deductible, higher cost plans that result in less cost sharing. And so we saw that disproportionately what was true before the Affordable Care Act was passed is that the poorest in our society were most likely to have the highest level of out-of-pocket burden. And so people who could afford to have private insurance and have even more expensive coverage for private insurance were the least likely to experience the significant out-of-pocket burden. And so the cost sharing was happening among the people with the lowest incomes, who also, statistically speaking, were those most likely to have significant comorbidity or mortality from illness. And so what we saw was that the system was incredibly unfair. It was significantly burdening financially those in our society who were least able to pay. And so that's one of the reasons why the Affordable Care Act put in place provisions that capped the amount of out-of-pocket costs for individuals per year at less than 9.5% of their annual income. And this is to deal with, in particular, the people on the far left-hand side of this diagram from having to spend so much on their health care. What we see here in this chart is what we see happening on prescription benefit cost sharing. Now, many health insurance plans include prescription benefits. Many of them have a separate prescription policy, so you need to think about and remember that. But what we see is happening here, and this is on employer-based insurance plans, that there's also significant cost sharing on the part of prescription drug benefits as well. And part of the reason why is very similar. What we see is more people pay for what we call third or fourth tier non-preferred or non-covered drugs. They pay much more out of pocket. And the reason for that is that there is a movement to try to push or try to incentivize people to buy the less expensive drugs, the generic or the preferred drugs. And so by increasing co-payments and increasing co-insurance, again, this is a great example of the belief that came from the RAND study that the more skin that people have in the game, the more they're asked to pay, the greater the disincentive to purchase things that may not be medically necessary. In many cases now, health insurance plans will not cover the cost of certain third or fourth tier drugs unless there is a medically necessary reason why someone cannot, for example, take a generic drug. And so what we see is a big push toward creating the financial disincentives for using some of the most expensive prescription drugs that are out there. Now, there are many different kinds of health insurance plans out there. We have these so-called indemnity plans that cover basically when there are certain kinds of catastrophic costs, and the relationship between the insurer and the provider doesn't really exist. The indemnity plan pays directly to the consumer, and then the consumer pays directly. So it's just a way of mitigating that and removing that middleman. What we see here again is that the insured, the individual, is paid in order to pay the provider for that service. And so that's how that works. We see this often typically in a lot of dental plans where the insurer doesn't work directly with the provider, but again, the insured is receiving the payment. We also have what is much more common, which is a service plan. Specific health services are paid by the insurance company directly to the provider at a specific rate. Any costs charged by the provider beyond what we typically think of as the usual and customary rate for those services are then passed on to the insured or the consumer. So this is where the insurance plan pays the provider directly. And this is what we see in most health insurance plans today. Now, some basic terminology you should be familiar with about health insurance benefits. A benefit is any service covered by an insurance plan. Oftentimes, it includes terms like a medically necessary service, a physician-ordered service, a pharmacy-based service, etc. But it's any service that a health insurance plan will pay for. What we also see is that oftentimes managed care organizations limit the kinds of benefits that are available to consumers to use by using terms like that they must be referred or pre-authorized by a primary care provider. So this is another way, again, of controlling demand by saying that the only way that certain kinds of benefits will be authorized to be paid is if they are done with permission of a primary care provider that participates in that managed care organization. So this is something that's very important, particularly managed care plans or health maintenance organization plans require patients to have something called a primary care provider that then provides the referral to any kind of specialized or highly expensive care. So it allows for that primary care provider to be what we call the gatekeeper to certain kinds of specialty or very expensive benefits. What we also see now, of course, is that the kinds of health insurance benefits that are provided by health insurance plans are no longer limited to newly occurring conditions. Pre-existing conditions are now allowed to be covered and are eligible for benefits due to the Affordable Care Act.